Good evening, everybody. Welcome to this another session of 50-second comprehensive course on echocardiography. Today, we are going to deal with evaluation of LV systolic function. And for that, we have a very eminent faculty in this particular program. I'm Dr. Rakesh Gupta from Jorop Institute of Echocardiography, Ultrasound and Vascular Doppler. And to tell you a very important thing, which I shared last time also, we got recognition from Indraprasth University, Guru Govind Singh IP University for our fellowship program of 6 months, only just about a week back. Well, we started this program in April 2000, and now we are in to our 52nd program, which started on 24th of September 2025. We have covered almost 14 topics, sessions till date. We talked about concept of hypokinesis, akinesis, dyskinesis last time. And today, Dr. Sanjay Mittal, who is an eminent cardiologist based at Medanta Medicity, looking after a directorship of heart failure program. And he's been associated with this program since last 25 years. All topics dealt on LV systolic functions are dealt by him only. With this few words, let me request Dr. Sanjay Mittal, please go ahead and share your thoughts, views, and enlighten these youngsters about LV systolic function evaluation by echocardiography. It's all yours, Sanjay. Thank you very much for being a part of this program. And we look forward for many, many years to go along with us together.
Thank you, Dr. Rakesh. I think it's always a pleasure being with you, uh, discussing echocardiogram. And I mean, there's no short saying this thing that you have been a pioneer, along with our stalwarts like Dr. Parashar, in making echocardiogram a need of the clinical cardiology all over the country. I think you have done enormous job in lifting echocardiogram to a clinical level in the country.
Well, I'm not
And
a
so,
single crystal transducer. One of the crystal is you also, man.
well, we need a driver. Without
Yes.
electricity, there is no transducer, right? You
Correct.
for the vibrations, you need electricity, right? So
Right.
that's what you are.
Thank you very much. It's all yours. You can share your slides. I'll go
Okay,
to
I'll
next
do that.
slide. Thank
I'll
you.
do
Thank
that.
you.
Great. So I hope I lived up to the expectations what you have created for me. And what I'm going to do today is maybe revise a little bit because I'm going to talk about the left ventricular systolic function. Obviously, there are a few lacunas here. One, I'm going to be predominantly focusing on the left side of the heart, that is left ventricle, and I'm going to be focusing on the systolic function. And whenever we talk about systolic function, one, probably as Dr. Rakesh Gupta said, they have already discussed about the concept of hyperkinesis, akinesis, and dyskinesis. But that becomes a very important stepping stone for my further discussions. So I am going to put my thoughts onto what your concepts about the regional wall motion abnormality is first. Then we are going to talk about the importance of left ventricular global systolic functions and what the advent in tissue Doppler imaging and strain rate imaging is going to be today, because that is no longer specialized echocardiogram, it's routine echocardiography today. So first, let me start with regional wall motion abnormalities or segmental wall motion abnormalities. You can call it RWMAs or you can call it segmental wall motion abnormalities. I think, as Dr. Rakesh said, this has already been conceptualized and discussed. I would like to highlight here what my simplified thought process is about this process is. Well, it all goes into the fact that whenever we look at coronary anatomy, and there happens to be a lesion somewhere in a distribution of coronary anatomy. For example, this is the LO view in this cartoon, and there is a block in the LAD. The area supplied by the LAD distal to the block becomes devoid of blood. And this leads to a cascade of events, which we call as ischemic cascade. which means the first thing would be the flow dipping, which is called as flow heterogeneity. Unfortunately, there is limited echo utility in calculating or assessing the flow heterogeneity. We can do so by doing contrast echocardiograms, but as of now, routine echocardiograms, it's difficult to actually assess for the flow heterogeneity. Thereafter, there happens to be metabolic alterations, which usually the carotid sinus or coronary sinus sampling can tell us. And sometimes the PET scan, which leads to metabolic assessments, can also gather that. Thereafter, there is diastolic dysfunction. Well, because the relaxation also is equally important energy consuming process, and we can assess by LV diastolic function assessment. Unfortunately, because of the fact that it is not sensitive to the ischemia or non-ischemic strategies, the problem is it is non-specific, and that is why we cannot put our money on a clinical evaluation of ischemia by diastolic dysfunction alone. The importance is the first step, which is very specific of regional wall motion abnormality, is this synergy originating from the fact that the area which is supplied by artery, which is occluded, leads to decrease in contractility in that particular area. And that is the important distinguishing feature. And you have already been told what segmental or regional wall motion abnormality is. For example, this is a four-chamber view. You'll all agree with me. And in this four-chamber view, on the left ventricle, leave the right ventricle aside, you can see there are certain portions of this left ventricle which are contracting pretty well. For example, the lateral wall. But if you look at the apical area, there is hardly any contractility there. Rather, this area bulges out during cardiac contractility. And this is what we actually are observing in this particular four-chamber view, that there are certain segments which are not contracting, rather reverse contracting in this particular case. And there are other segments which are contracting reasonably well. And these segmental abnormalities of wall motion are actually, for all practical purposes, considered to be a sign of ischemia until and unless proved otherwise. On the other hand, if you have all the areas of the left ventricle equally non-contracting or less contracting, like global hypokinesia, whatever, this is to be proven to be ischemic by relevant tests. We're going to discuss about those things subsequently. But whenever there are regional volume motion abnormalities, we have to consider ischemia as the priority until unless it is proven otherwise. Yes, there could be times when there could be regional abnormalities, which could be because of non-ischemic origins, maybe patchy myocarditis, sarcoidosis, something else. But then there is a pattern to this, and we are going to discuss that also in the subsequent sessions. So, what we have to understand whenever we talk about wall motion abnormalities is a few points. Point number one is we have to learn to assess the left ventricle and break the left ventricle into 16 to 18 equal segments. When I talk about simplicity, I talk about 16 segment scoring system, which is on your left screen. 17 and 18 segment scoring systems have also been used, but I think 16 segment is very practical and very user friendly, and I would adhere to that. And most of the echocardiograms actually adhere to this 16 segment scoring system. The 18 segment scoring system is simplified, the single line drawing all the three areas, that apical, mid, and basal segments into six each. That means 18. And this is usually done by computerized systems when we talk about spectral tracking. And I'm going to discuss about it later. We talk about the 18 segment scoring system. But conventional echocardiogram usually still uses 16 segment scoring system, where we have six segments at the base, six segments in the middle, and this is what we have, the apical segment, which is only four. And I'll tell you why we have to use that marker for our portfolio. So the other thing which I'm going to discuss about is the fact that we have to learn to actually integrate the various segments into different views. In the center here, you see the short axis view where you have this right ventricular free wall and you have the short axis of the left ventricle at the level of papillary muscles. Mind it, this is when we put the transducer in the parasternal area and the ventricle is cut in the short axis view. When we rotate the transducer in the long axis view, looking at the left ventricle in the long axis, the fact what happens is from the anterior portion, the beam passes through the left ventricle. It cuts the heart in such a fashion that we look at the right ventricular outflow tract here, which is the anterior portion near about the right ventricular outflow tract. Then it cuts through the anterior portion of the interventricular septum. We call this anterior septum. And then we cut the ventricle into the posterior wall between the two papillary muscles. If you see the inferolateral and inferior posterior and anterolateral papillary muscle are not originating from the posterior wall. And this parasternal long axis view would show us the right ventricular outflow tract area. This would be the anterior septum, and this would be the posterior septum. So this is what we see here. And we have to understand that this is the posterior wall here. Just adjacent to the mitral valve would be the basal segments, the mid segments, and apical is something which we refrain from advising for the posterior and apical septum because many a times it's not seen and it's not covering the right ventricular free wall. Next would be if we remove the transducer away to the apex and cut the ventricle into the longitudinal fashion, we would be seeing the right ventricular free wall, a posterior side of the interventricular septum, and the lateral wall. And mind it, lateral wall gives rise to the anterolateral papillary muscle. So if you look at the four-chamber view, we look at the left ventricular septum. Mind it, we don't call it posterior septum. And there is a reason for that because this septum itself is distributed from base to the apex. And the apical region, we do not have a distinguishing feature between anterior and posterior septum. It's just the septum. And that is why the whole part of this area seen in the four-chamber view, we call as septum. And this is divided into the basal third, mid third, and apical third. The lateral wall, which gives rise to the papillary muscle here, is divided into three parts: the basal lateral, mid lateral, which gives rise to the origin of papillary muscle, and the apical lateral. So one way is third, 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 and the other one way is to actually identify the landmark of papillary muscle, which arises from the middle segments, and beyond that is apical, and before that is basal segments. So this is a very easy way of distinguishing various segments. And when we rotate from the apical view at 60 degrees, what we find now is that we lose the right ventricle completely. So there is no right ventricle here, and there is no right ventricle here. What we have here is that this would be posterior inferior papillary muscle originating from inferior wall and the anterior wall, which is just beyond the insertion of the right ventricle. So we would have anterior wall and we will have the inferior wall. And all the length of the left ventricle is divided into three parts: the basal third, middle third, apical third, or as I said in the four-chamber view, the middle part giving rise to the posterior inferior papillary muscle. And that's why we can say before that is basal segment and beyond that is apical segment. Same way for the anterior wall, basal, mid-third, and apical third. So this way we'll have 3 plus 3, 6 plus 3, 9 plus 3, 12, and 4, 16 segment scoring system. That is something which we understand. Now, the second important thing about what I'm going to discuss today is out of these 16 segments, we have to learn to understand how does coronary anatomy distribute itself in these 16 segments. So let me explain a little bit. This is a short axis view, just a Q, as I discussed in the previous part. What would happen here, if we look at the LED runs in the anterior part of the interventricular groove. The right ventricle and the left ventricular groove is this. And it runs all the way from the base, winds around the apex, and goes beyond. Most of the times, more than 55 to 60% of times, the LED is actually long enough going from the base to the apex and then winding around the apex. Right? This is what we have as a common LED territory. And obviously, the wherever the LED is going, it would supply the parallelly septal branches supplying the anterior septum area and the diagonal branches supplying the anterior wall. So if we look at the longitudinal supply, it would supply the basal anterior, mid anterior, apical anterior, and when it winds around the apex, the apical inferior as well. In the four chamber view, if you look at what segments are supplied, the mid and basal lateral are not supplied by the LED, but usually the apical lateral and apical septum, all the apical segments, four apical septums are going to be supplied by the LED. And the parasternal long axis view, the basal and mid anterior septum is supplied by the LED. So 1, 2, 3, 4, 5, 6, 7, and 8. 8 out of 16, more than 50% of the area of the left ventricle is supplied by the left anterior descending artery. Let's look at the other artery, which is circumflex. When the circumflex arises from the anterior portion, winds round the AV groove, and from it gives rise to OMs, obtuse marginal arteries, running from the base towards the apex, from the base towards the apex. So the first obtuse marginal artery would be supplying the lateral wall, and the subsequent OMs would be supplying the posterior wall. So commonly, this is the common distribution. However, when the circumflex is small, it may be just supplying the lateral wall. And when it is exorbitantly long and sometimes supplying the PDA as well, it may overtake the inferior wall as well. So what we have here is commonly the mid and basal lateral and mid and basal posterior is supplied by the circumflex. And as I said, the lateral wall is by the proximal branches, that is OM1s, and posterior wall, the distal portion is supplied by the OM2s and 3s. So this is how we have, and usually in a common distribution, 1, 2, 3, and 4, 25% of the myocardium is supplied, 20 to 25% myocardium is supplied by the circumflex, unless it's too small or too big. If you look at the PDA, which usually arises from the right coronary artery, and then it continues into the PLB branches. The PDA supplies the septum, basal and mid septal area, and the PLBs supply the inferior wall. So if we look at the four-chamber view, we'll have the basal septum and mid septum supplying by the posterior descending artery, which is a branch of the PDA, RCA, right coronary. And the continuation would be supplying the basal and mid-inferior wall. This is the common distribution. Again, sometimes the RCA may be too long, supplying the posterior wall also, and sometimes it may be too short, not even reaching the posterior AV groove, and all in area in that situation is supplied by the circumflex. But commonly, again, about 20 to 25% myocardium is supplied by the right coronary artery. If you look at how the three coronary arteries are distributed in the common terms, the four-chamber view actually commonly represents all three arteries. As I said, the LAD, the apical segment, the right coronary through the PDA supplying the septal areas, mid and basal, and the lateral wall usually supplied by the proximal circumflex branches. So four-chamber view shows all three arteries. Otherwise, in parasternal long axis view, you have the LAD territory and you have the circumflex territory. In two chamber, we have this right coronary and the LAD territory all the way around. So it is four chamber view which shows the presence of all three artery distribution, and this is something which is so very important to understand. One more thing which we can do is if we have short axis views at the apex, at the mid level when we see the papillary muscles here, and at the mitral valve level, which is the basal segments, and we combine all three together, we can draw a bull's eye plot like this. This is the basal apical segments, the middle, which is the papillary muscle areas, and this is the basal ones. And again, we see the LAD. LAD goes into the AV groove all the way around and winds around the apex, supplying all the areas, the anterior wall, the anterior septum, basal, and mid, as well as all four apical segments. So this is LAD territory. The circumflex winds around the apex, the AV groove, and gives the OM1, OM2, and 3, supplying the lateral and posterior walls, and the PDA as well as PLBs supplying the septum, mid and basal, and inferior wall, mid and basal. This is the common territory, a common distribution of the territory in the bullseye plot. The fourth thing which I would like to mention to you today is we are all fancy of numbers. And the number means how to actually translate the wall motion abnormalities into an analyzable numerical digits. And this is something which we have to understand. And you already have been mentioned the concept of normokinesis, hypokinesis, akinesis, dyskinesis, and aneurysm and scar. And I think, as Dr. Rakesh was mentioning, we have already discussed in the previous classes. Normal kinesis means there's about in systole, the thickness of the myocardium increases by 50%. So if the diastolic thickness was 1 centimeter of a particular segment, it should increase by 50%. That means about 1.5 centimeters or more in systole. This is normal. Maybe more hyperkinesis or normal. This is something which is relative to the rest of the segments. Hypokinesis is when the thickening is 20 to 50%. That means the diastolic thickness of 1 centimeter becomes in systole 1.2 to 1.5. Akinesis is when the thickening is less than 20%, 10% or whatever. Dyskinesis is instead of thickening, increasing the thickness during systole, the segment actually thins out. And the last one is aneurysm. This is important to be understood that in aneurysm, what happens is there is instead of diastolic thickening, there's thinning, but also there is outpouching even in diastole. That means the contour of the left ventricle is deformed even in diastole, which is an elevation of an amount of myocardium which is surviving. So this is the numerical ways, but practical way is a simplified one. Normokinesis is that what you have learned all the way through your ages to understand what is the normal contracting myocardium. What is not, what is seen to be contracting but not normal is hypokinesis. And where your eyes fail to perceive any change in thickness in systole is akinetic. And when you're seeing an outpouching and thinning during systole, it is dyskinesis. And when you're seeing an aneurysm or a area deformity, even in diastole, this is aneurysm. And we can rank this as a numerical value of increasing score of 1, 2, 3, 4, 5. 5 means the worst or aneurysm. And the higher we go, the lower we go, 1 to 5, the prognosis worsen out for that particular segment. And as we go beyond 3, 4, and 5, there's hardly any chance of surviving myocardium during in that particular segment. And that is something which was be important as we go down. The chances of surviving myocardium in that thickness is less and less. And the prognosis worsened out. So when we talk about wall motion abnormalities, mind it, a good echocardiography would mean that we just don't say that, yes, there is a wall motion abnormality present or not. We should be able to mention whether it is, what is the severity. That means whether it is hypo, akinetic, dyskinetic, or aneurysm, whether there is a scarring, and scarring by it means either calcification or by a very fact that it is fibrotic, which is a very big characteristic, echocardiographic characteristic of a muscle which is becoming fibrotic and whitish. Which vascular territory are we talking about? I'm talking about also, as we discussed right now, is it the LAD territory or is it the right coronary artery territory? Is it double vessel territory, single vessel territory? We should be able to figure out and describe in greater detail. Mind it, I would say that it's not only that, we should be also able to figure out whether it is a proximal LAD lesion or a distal LAD lesion in many important studies, which would be also of prognostic value. Let's talk about a few cases. You'll agree with me, this is a parasternal long axis view, because right now we are talking about a monologue and you'll just be a passive listener till the time you are allowed to interact. But this is a parasternal long axis view. And this segment, just akin to the aortic valve here, is a basal anterior septum and the mid anterior septum, one third and one third. We don't talk about the apical segments in the parasternal nervous system. So we see the basal anterior septum is contracting reasonably well. The thickness is increasing during systole. However, if we talk about the posterior wall, which is opposite to the basal anterior septum, mid anterior septum, the basal, posterior, and mid posterior wall, when the ventricle is contracting, the segments are not only showing no thickening, rather they are moving out. The movement is away from the center. That means they're outpouching. And this is a dyskinetic basal and posterior wall and mid posterior wall. So going back to the understanding of the territories, the basal and mid anterior septum was supplied by the proximal LAD, left anterior descending artery, which branches? Septal 1 and septal 2, right? What artery supplies the posterior wall is the distalmost portion of the circumflex, the OM2s and OM3s, right? So this is likely to be an area of infarct related to the circumflex artery where the LAD seems to be well preserved. The same patient, now we look at the four-chamber view. From the parasternal axis view, we have graduated to four-chamber view. And what we see here, which segments are we talking about? This is the basal septum, not basal anterior septum. Basal septum, mid septum, and apical septum. Basal and mid septum supplied by the posterior descending artery, which is usually the branch of the right coronary artery, right? So this is seemingly good, thickness maintained and contractility well. Apical septum also contracting well, and apical lateral. If we forget about this area, the apical lateral also is contracting decently well. There is endocardium excursion, which we can see. So this area, as I said, was the distal LAD segments, which are moving fine. The posterior descending is moving fine. And let's talk about the lateral wall now. The basal lateral is not showing me any thickening. It is akinetic. And mid lateral is also not showing me any thickening. Rather, it is standing there where it is. So this lateral wall was supplied by basal and mid lateral was supplied by the proximal circumflex lesion, right? So what we can see is in this particular patient, we have four segments which have yet been identified as almost akinetic, which was basal and mid lateral and basal and mid posterior, which are both supplied by the circumflex area. And that is why it is likely to be proximal circumflex lesion. If you look at the two-chamber view here, we can see the inferior wall, which is contracting pretty well, and the anterior wall, which also is contracting pretty well. So LAD and RCA territories are okay. And this particular patient is for sure showing infarct in the left circumflex area, which is likely to be a proximal circumflex area infarct. This is a complete paradigm of this, that what we see again, a parasternal long axis view, is this particular segment was basal anterior septum. We see hypokinesia, thickening is there, but it's definitely much less as compared to the normal segments, which is the posterior wall. In this particular patient, the posterior was is fine, basal and mid, but anterior septum is hypokinetic basal segment and akinetic mid anterior septum. As I said, basal anterior septum is supplied by the first septal artery of LAD, and first septal is the proximal LAD. So this likely to be a proximal LAD lesion, and a worse prognosis is going to be there. Lastly, a few things about problems which can arise when we do the assessment of wall motion abnormalities hurriedly or wrongly. Reason being that it is a two-dimensional assessment of a three-dimensional motion of the heart. The heart is not only contracting like this, it is contracting and changing its shape. And we'll discuss about that subsequently. So that is why we have a confusion here. We should always not talk about just the motion. We should talk about contractility, that means change in thicknesses. And that is something which is so very important. Giving you example, in this particular patient, what we have is basal, again, parasternal long axis view. Basal anterior septum is contracting pretty well, and mid anterior septum also seems to be going in. But if you very carefully look at the mid anterior septum, there's hardly any change in thickness. It is moving in all right, but there's no change in thickness. And this is because of the fact that this hyperkinetic segment is pulling this adjacent segment inside. So there is a motion, but there's no thickening. And that is why what we call here is movement without thickening is not a sign of life. We have it because of pull effect. When the heart rate goes up, when there's hyperkinetic segments, sometimes they can pull the adjacent segments. And what happens is it would make us believe there are better heart functions when actually it is a poor outcome area. The paradox happens when we look at this particular patient. The lateral wall seems to be contracting well, and the septum may not be seemingly contracting. This is so because in many cases with what we have is left bundle branch block, WPW or pacing, the septum actually starts contracting earlier, and that is why there's a septal bounce which is seen, paradoxical septal motion. This is basically because of the fact that septal contractility happens much earlier. So when the whole of the left ventricle, rest of the left ventricle is contracting, by that time the septum has already contracted. And when the rest of the segments are contracting, it seems the septum is not contracting. And that gives a false sense of wall motion abnormality, and we should be very cautious about in these situations. Another problem, common problem, which happens in assessment of wall motion abnormalities is, and that is why I always say, go by landmarks. So, for example, this is a parasternal long axis view. Commonly, this would be basal anterior septum and mid anterior septum, and this would be basal posterior and mid posterior, right? This mid posterior and basal posterior supplied by the circumflex artery. But what we see here, fail to realize, is this is a papillary muscle region. Posterior inferior papillary muscle never arises from the posterior wall. It arises from the inferior. And this means this is the inferior segments, because of the cardiac rotation and malposition of our transducer, is not showing us mid posterior, but is showing mid inferior. Commonly, mid inferior is right coronary artery territory and not the circumflex territory. And there could be a gray zones, fine. But we would rank a wrong interpretation of wall motion abnormality if we don't identify the landmarks. Similarly, if you look at this, this is aorta. And when the aorta is opening, this means we have moved fallaciously the transducer towards the anterior part of the septum rather than the posterior part. And this no longer remains a basal septum. This is likely to be basal anterior septum, which is LAD territory, not the PDA territory. And we may actually make a single vessel disease appear to be double vessel disease and reduce the prognostic outcomes of the patient. One more thing, very commonly which we have understood is this is a classical example. In this particular four-chamber view, we see the basal lateral, okay, papillary muscle origin, fine, mid-lateral, perfect, apical lateral is maybe a little less contractile, hypokinetic, apical septum is also hypokinetic, mid and basal septum are doing fine. The ejection fraction, if you look at, maybe easily 40, 45-ish, right? On the other hand, let's look at a comparator four-chamber view. This is again another patient, another four-chamber view, where we have a basal septum, okay, mid-septum hypokinetic, apical septum akinetic or to dyskinetic, apical lateral akinetic, mid-lateral is hypokinetic, and basal lateral is normal. So only two segments seem normal, and there are a lot of wall motion abnormalities. Ejection fraction here would hardly be 20-25%. And this is a very common, difficult thing to understand that both this 45 is seeming ejection fraction, 25 seeming ejection fraction is on the same patient taken just 3-4 seconds apart just for the purpose of discussing here. Why? Because this is a very common error of foreshortening. If you look at where the transducer is in this particular view is at this particular location. The whole of the apex, if you look at, follow this laser pointer, is at this particular point, which is never going to be in the view. And this is a very common mistake. If you can follow my chest here, we start the parasternal long axis view and then slowly move out. And as soon as we see the four chamber view, we say, wow, we have gotten the four chamber view, and we do the calculations. Ideally, we should keep on moving out and down till the time we lose the heart and then come in. We not commit same kind of mistake. Otherwise, we can easily make a very bad ventricle a very good and deprive of timely action to this particular patient. One more thing, as far as wall motion abnormalities is concerned, as I was mentioning, this is a scar area, and here there's calcium. Because of this, the endocardium is not seen, whatever happening inside. And whenever we don't see the endocardium, we should refrain ourselves to mention that there is wall motion abnormality. Here also, I can't see any endocardium on the lateral wall. And mind it, 5 to 10% of people, when we do echocardiograms, we don't see the endocardium well. And in these particular patients, either we should do a contrast echocardiogram or refrain bad echo windows, and don't feel shy that we could not make out. Something else could be done in these patients. So, one more thing which I would like to mention here, besides this dictum, which I say that have courage to report could not be visualized rather than giving a wrong information and depriving the patient of the right treatment. We also have to understand that wall motion abnormalities cannot distinguish in an acute coronary syndrome whether the person has had infarction or whether the person has angina. It cannot acutely differentiate between a dead and alive myocardium. And so we cannot base, on the basis of all motion abnormalities, the decision to thrombolyze. It is only on the basis of EC changes that the person should be taken for thrombolysis, or otherwise, yes, we can decide about taking the person to the cath lab and confirming and treating it that way, but not thrombolysis. The second component of my talk today is go from the regional wall motion abnormalities to global. And the global wall motion abnormalities is, as we all understand, is dependent on ejection fraction calculation. We have been all over the globe talking about leaving ejection fraction aside, so much variability, so less dependence, and every damn thing. But mind it, it's going to stay with us because all the treatment guidelines for heart failure is based on ejection fraction. ICD or no ICD, ejection fraction, 35 or less. CRTD based on guidelines based on ejection fraction, 35 or less. Heart failure treatment, well, we know HFrEF has a lot of opportunities, HFpEF, midref has limited opportunities. So it is all ejection fraction based, and it's going to stay with us for a good time to come. So we better just mind it. What we have been doing in our common clinical practice is using M mode to calculate the LV volumes. I deplore it. I actually condemn it, and I don't want anybody of us to do Ticolo's method to do ejection fraction manipulations, because this is a three-dimensional heart, and we are using single dimension to mention about the volumetric changes, which is wrong. Better to understand the Simpson's method, that the whole length of the left ventricle is divided into equal segments, and each segment is considered as a disc. The volume of each disc is summated enough to give the end diastolic and end systolic volume, and this gives us a three-dimensional volume. Unfortunately, in our clinical practice, we are not using Simpson's method. We are using two-plane modified Simpson's method. And this is why the actual 3D echocardiogram can actually give us the realistic Simpson's method, but not the commercially used Simpson's method, which you do in echocardiogram. So what happens here is the end diastolic frame is frozen and end systolic frame is frozen. The end diastolic frame is actually then traced out, and the machine actually gives us the length. The whole of this length is divided into equidistant 20 segments. And each of this segment is then extrapolated to give us a circumference with a long and short axis, which is calculated by a four-chamber view. So this is one view. Then we should always repeat it in a two-chamber view to give us a biplane a modified Simpson's method. And summation of this end diastolic and end systolic volume would give you end diastolic volume, systolic volume, and stroke volume. And by way of which we can calculate ejection fraction. The guideline says normal ladies have 60 to 70, ejection fraction is normal. Men have 55 to 65 as normal. Anything less than 50 is abnormal ejection fraction. 40 to 50 is mid-range LV systolic dysfunction, and less than 40 is systolic dysfunction, which leads to heart failure with reduced ejection fraction. And the treatment guidelines are still based on this particular thing. One more thing which I would like to mention here, whenever we calculate the ejection fractions, we have to actually mention about two things. Both end diastolic and end systolic frames are times when both the valves, the mitral as well as aortic valves, are closed. So these are dimensions should be taken in isovolumetric contraction and isovolumetric relaxation phase, when both the valves are actually closed. So isovolumic contraction means that the volume has actually not started to eject into the aorta, and the end diastolic volume is there. And isovolumic relaxation is that the ventricle has started relaxing, but the volume has not changed to accommodate opening of mitral valve, and this is the end systolic volume. So these are the times variance we should look at. And always have experience, because I think today, yet the best way to calculate and in the ejection fraction, the practical terms, is your eyeballing, specifically when you have enough experience. If you are a beginner or if you are actually doing assessment for research purposes, there's no second thought or the confusion. You should always use this modified Simpson's method. The last component of my talk today is going to be a concept on strain rate imaging. How did it come? The importance was, as I said, the left ventricle is not just coming in and out. it is also writhing. Like actually, when we are writhing the clothes to remove the extra water, that's how the ventricle behaves. What happens is there are circular components of the muscle which take the ventricle clockwise in the basal portion and counterclockwise in the apical portion. That means the apex goes or the opposite direction. You can see this here. The apex is also moving counterclockwise, and this is something which we have to understand. One of the reasons why we have to understand the three-dimensional motion of the left ventricle. The concept of strain rate is that just like a finger prints, each ventricle has a different pixeling. And all these pixels are actually inbred by machines, and they can recognize all those pixels and the relative motion of those pixels in space, in time. So what happens is that the machine can detect the change in distance between these two pixels and draw whether there is shortening or there is lengthening. So normally, whenever there is a contraction in the four-chamber view, there should be shortening between the two pixels, and this could then be plotted on the basis of the relative change in dimensions into the four-chamber view. So today, what we have a simple translation is the four-chamber view. We can draw the endocardium, and the machine then actually draws the region of interest and tracks all the pixels in this particular fashion in their relatively shortening. You can see all the greens, which is the apical septum, the blues, which is mid-septum, and the yellows, which is basal septum, the red, which is basal lateral, the dark blue, which is mid-lateral, and pink, which is apical lateral. And then the change in the volume or relative distance could be drawn in the term of time, and this can lead us to actually not only tell us what change of volume per segment is, segmental ejection fraction can be calculated, also which segment is less moving, delayed contraction, everything can be detected here in this particular graph. And mind it, because it is mechanized, it is easy to do. One more important thing is if you do not see the endocardium well and the machine is given garbage to actually analyze, you'll have garbage out. You would not have good interpretation. So for this also, giving the machine a proper image is important. The normal global longitudinal strain is minus 20 or less. Less, why? Because it's a negative value. Negative value because it is shortening in systole. So in the systole, the length is lesser. That is why the value is negative. And we can also M mode play here. The whole of this segment, the whole length could be drawn as a single segment. This segment being yellow, that means basal septum, mid septum, apical lateral, mid lateral, and basal lateral, which can then draw a timed fashion contractility and show us how and when it is lengthening and shortening is normal. So that's how it can give us a complete picture of assessment. And again, as I was mentioning, the bullseye draw can also be there. We can see the segmental shortenings, and this could be then drawn. For example, in this particular fashion, the basal segment seems to be less contracting as compared to the apical segments. And this is something which can be given to us. Today, where the GLS, global longitudinal strain, is being used is because of the fact that it is definitely machine dependent. Until unless the image is absolutely scrappy, it is reproducible, and it is now the machine to machine variance is also minimized and has a good prognostic value. Um, we also have other things which can come up, circumferential strain, when the circumference is taken into consideration. Again, the circumference with systole reduces. So again, this is also a negative value of the same magnitude. The radial strain is the third strain which we can get. In systole, what happens is the thickness of the ventricle actually increases. Rather than decreasing, the thickness increases. And that is why the radial, because the thickness is increasing, this is a positive value. And again, more than 20% increase is expected. And that is why it is called as a positive radial strain. Unfortunately, circumferential and radial strain is still experimental and not available for common clinical use. Lastly, I'm going to end here with this particular case. This is a four-chamber view, two-chamber view, three-chamber view, and a long axis view in a person who was then put on a exercise testing. And what we found here, the longitudinal strain at the apical view was lesser as compared to the basal segments. Although the wall motion abnormalities were not evident here, but the strain can actually, pick up earlier wall motion abnormalities. And this is why today the recommendation of using strain rate imaging today is in wall motion abnormality, as well as assessment of stress test early changes, which is very common. So this is what had for all of you guys. I'm going to stop my presentation here and ready to answer any questions if you have.
Okay, friends, let's have some question answer session. Please post your questions or raise your hand so that I'll request Dr. Sanjay Mittal to answer them. हो चुका आधा घंटा आधा घंटा Anybody has a question? I think Sanjay, they have learned a lot today, man.
No, not at all.
No, they have not learned anything. So the first question has come up already. Roll number 26, Dr. Swami.
Good evening, sir.
Good evening.
Sir, how can we see, is it a left main or proximal LED and distal LED, sir? Can we identify left main in the...
Yes,
Yes.
you can. Left main commonly would be giving origin to LED and circumflex, and both in the proximal areas. And mind it, whenever we are talking about ischemia induced by left main, it is a catastrophe because almost more than 75 to 80% of myocardium should be ischemic. So usually in situations like this, we find global hypokinesia because right coronary artery alone is not able to supply enough blood to the rest of the myocardium, and almost all segments become hypokinetic. And usually, as I said, catastrophe, because if there is an acute infarct of left main, there is hardly any time for the person to develop arrhythmias and cardiogenic shock and syndromes like this. So yes, when we're talking about left main, it's a very huge area. Usually the person has hemodynamic compromise. As I said, the LED proximal to distal is, as you just trace the course of the LED. LED starts from the basal segments, goes to the apex, and then winds down the apex. So if we talk about the distal LED, only the apical segments would be involved. If you talk about the mid segments of involvement in the LED infarct, that means it is the at least the mid anterior wall and mid anterior septum, which should also be involved. And if we have a proximal segment, then obviously proximal means it would always be associated with an apical infarct as well. So when we talk about the basal segments, basal anterior septum, basal anterior wall, just like the case I showed you, if that was involved, there is no possibility that the apex would be spared.
Yes, sir.
So it is basal segments, mid segments, and apical segments all would be involved. Then it is proximal, only apex involved. That is a distal LED.
Thank you, sir.
Anybody else? Okay, online roll number 2, Doctors Rafat Jahan Manzoor Ali Sayyed.
Good evening, sir.
Good evening.
Sir, I want to know how to identify proximal or RCA lesion on echocardiography and proximal LCX lesion.
Okay. So when we talk about proximal right coronary artery, you have to understand the course as well as the distribution. Till the time the right coronary artery reaches the posterior AV groove or the crux, it is only supplying the right ventricle, right? Acute marginal branches supplying the right ventricle only. When it reaches the crux, it actually supplies a PDA, which supplies the basal and mid septum, and then it may continue into the AV groove to supply the posterior left ventricular branches, which supply the inferior wall. So, if we talk about the proximal right coronary artery, you would expect specifically if the right coronary in as much as 55% of patients is dominant, then it would be supplying the PDA as well as PLBs, and that means inferior wall as well as the basal septum would be involved. And the right ventricle also may show infarct or hypokinesia or dilatation. This is a common manifestation of a proximal right coronary artery lesion. And many a times these patients have blocks, heart blocks. What happens on the other side is if the person has distal, the right coronary artery does not have any ischemic effect on the right ventricle, and the right ventricle may be preserved. So, involvement of the right ventricle, dilatation, hypokinesia of the right ventricle, hypotension is a sign of a proximal right coronary artery lesion. On the other hand, circumflex, as I said, is running in the AV groove from anterior to posterior side. And as I said, when you are starting proximally from the anterior side, lateral wall is the first thing you supply by the OM, first OM. So the proximal circumflex means there would be involvement of the lateral wall, and the distal circumflex means the posterior wall. I showed you a case where the both lateral wall as well as posterior wall was involved, and this means the circumflex had to be involved in the origin.
Thank you very much, sir. Thank you.
Okay, Dr. Ruchi Saran.
Sir, I wanted to ask, you said if there's a calcification, we'll not be able to see beyond that the contractility. So, how do we measure in those cases? And also, is there any way to differentiate calcification from fibrosis?
Right. These are the basics of echocardiogram. We have to understand it is ultrasound beam which is emanating from the transducer, going through the soft tissue, and then rebounding back. Whenever there is a hard bone, calcium is a bone, right? The rebound is almost complete. Nothing passes, the ultrasound does not pass through the bone. Everything is rebound back. So what happens is when everything is rebound back from the calcium and we cannot have any ultrasound imaging distal to the calcium, the endocardium, which is distal portion, may not be seen. Right? This is the same thing which happens with metals, same thing which happens with calcium, and surprisingly, not surprisingly, very importantly, happens with air. Because air and tissue creates again a complete reflection where nothing is seen beyond that particular capacity. So when you're not seeing the endocardium, you cannot see the thickening. So yes, there are two things. Wherever there is calcium, calcium is a result of damage, a repair process where the myocardium has been injured, long-standing, and replaced by calcium. However, even if the calcium is not because of the myocardial injury, other hypercalcemia related stuff, we cannot see the endocardium beyond it, and so we should not comment on thickness changes in systole and diastole. In situations like this, you can resolve to images where the calcium is not coming into the path of the ultrasound. For example, if the anterior septum, just like what I showed you, was showing the calcium, it should be then a four-chamber view when the apex is not calcified, or some other view where the ultrasound is not passing through the calcium. You can see then the endocardium, and you can afford to actually comment on that. But the pathway of the ultrasound beam should not be through the calcium. That is one. Second important thing which you asked is the difference between fibrosis and calcium. As I said, fibrosis is not calcium and there is no complete reflection. That means some of the ultrasound beam would pass through the fibrotic tissue and you would still be able to see the endocardium beyond that. So fibrosis appears as a eco-dense area because there is no water there. Muscle has more water as compared to the fibrous tissue, and the fibrous tissue appears more white as compared to the grayish area of the muscle. You'll come to know when you see those fibrous tissues. But at least you'll have some ultrasound being passing through it, so there is no negative shadowing. Wherever the calcium speck comes, there's a wedge which forms. If there is a calcium here, there is ultrasound which cannot pass here. There's ultrasound which cannot pass here. So you'll see a wedge of nothing seen beyond that. So a triangular thing beyond the calcium, which you would say nothing seen, which is a sign of calcification, not fibrosis.
Thank you, sir.
All right. Dr. Varun from Agra. Dr. Varun, go ahead.
Yes, sir. Good evening, sir. So,
Good
as you
evening.
have said, M mode is now absolute in case in measuring ejection fraction. Sir, if we are in some cases we are not able to make good windows apical four chamber view, then can we use M mode to some extent, or how much extent it is not correct in comparison to Simpson method, as you have said?
So there are lots of variabilities. One of the things which I try to show there is whenever you're doing an echo, the heart is not always like this. Parasternal long axis is not always like this. Many times the best view you can get is when the apex here and the base here is not in the perpendicular axis to the beam. It is tangential. And what the machine would do is it would draw a line of M mode like this. So you would be actually looking at a tangential dimension rather than the actual thickness. And this is an overestimation of the volumes as well as underestimation of the ejection fraction. Many a times what you do is you take, if not the four chamber view, whichever view is happening, you should take that view and have a visual assessment of ejection fraction rather than talking about modified Simpson. Most of the times, if you can actually make out a good Simpson's method in greater than 90% of people. Many times what we do, and especially Dr. Rakesh Gupta, we can give them contrast which delineates the endocardium better, and then we would be able to come out with the calculation of ejection fractions.
Yes, sir. So one more question, sir. Is contrast study is safe in pregnant patient?
Very nice. The answer to that is ultrasound is safe to do, and contrast, what we are talking about today is not air contrast. We are talking about the micro bubbles which are available. Yes, you're right. There should not be any allergic response because most of these have some kind of protein contents. And we tend to avoid anything unproven in pregnant ladies. But there's been, I mean, unless the person is allergic to them, there should not be any reaction we can find. I think there have been a lot of studies where contrast has been used.
Yes, sir. So one more question, please. Can I ask?
Yeah.
सर सर एक मतलब मैंने बुक में पढ़ा हुआ था सर, जो हम एनुलस देखते हैं, जो एट्रियो वेंट्रिकुलर ग्रुप होता है सर, जो वाल्वुलर एनुलस होता है, तो उसका जो मूवमेंट होता है मतलब इन कंपैरिजन टू एपेक्स, जब हार्ट जो आप बता रहे हैं 3D मूवमेंट होता है, तो हार्ट का एनुलस ऊपर तक जाता है, तो क्या हम उससे भी एक्यूरेटली मेजर कर सकते हैं एनुलस और एपेक्स के मूवमेंट के कंपैरिजन को देखते हुए?
Yes and no. I think this portion of discussion would be happening when we talk about diastolic functions, because E prime is very much dependent on the annular motion, which is the first thing which actually gets usually dissipated in a drop in ejection fraction, the earliest change. And we would discuss about that later. What is important is that you are still seeing a single dimension movement.
Yes, sir. Okay,
We
sir.
are talking about multidimensional contractility of the ventricle. It is circumference reducing,
Yes, sir.
right?
Yes,
And
sir.
circumference reducing at all the apex, mid, and base levels. The circumference reducing and the motion being opposite direction, counterclockwise and clockwise at base and apex, and also the length shortening.
Yes,
So,
sir.
difference in the shortening is actually the earliest one to come when the left ventricular systolic dysfunction starts to happen. And that is why GLS actually starts dropping much earlier than the ejection fraction drop happens. So this is absolutely, that's what I tried to show you in the description. But what happens here is that we should not extrapolate to the different levels, because GLS drop is the first sign, probably preempting heart failure with preserved ejection fraction or mid-range ejection fraction. But when we talk about the criterion for various therapies, this is unfortunately still based on the ejection fraction drop, not the GLS drop.
जी जी, ओके सर, ओके सर, थैंक यू सर.
Thank you, Varun. Let's go to Dr. Rakshpal Singh, Jhansi. Dr. Rakshpal?
What is global hypokinesia, sir?
What is?
Hypokinesia.
Hypokinesia.
Okay. One is the theoretical definition, one is the practical definition. The theoretical is that the contraction changes from diastolic dimension to systolic 20 to 50%, right? That is a 20% thickening to 50% thickening in systole of a particular segment. This is theoretical because nobody is able to accurately measure 20 to 50%. Practical way is you can have two mechanisms. One first mechanism is if you lose hair as much as I have and as much as Dr. Rakesh Gupta has and has seen so many echocardiograms, you can from a far distance understand this area is normal or not normal, right? And if the contraction is definitely there, but it is not normal, you call that area hypokinesia. There is another way that in your only the same patient, there are areas when we talk about regional wall motion abnormalities, there in the same ventricle, there are areas which are contracting pretty well, rather hyper contracting to actually compensate for that particular loss of heart function, which we call as normal. And anything which is not contracting in proportion to what is so-called normal segment is called as hypokinesia. Many a times, the contraction may be 50%, yet it is not as much as the compensatory hyperkinesia was there, and yet we call it as relative hypokinesia. So that is something which we have to understand practically. One, the first definition which I said, because when we look at the ventricle, we have seen so many ventricles, all area is not contracting well. This is global hypokinesia. And to call it global hypokinesia, we need experience. On the other hand, when you talk about regional hypokinesia, we have to look at what areas in that ventricle are normal contractile, and compare that segment's motion to that normally contracting ventricle and call it hypokinesia or ekinesia.
All right, Dr. Rakshpal.
ठीक है.
Okay, anybody else? We have one more. Dr. Parveen Tasir.
Good evening, sir.
Go ahead, Parveen.
Sir, my question is, whenever the scar tissue or like non-contact tissue with hypericosity, so sir, sometime like it's confusing. So can we use any reference point like pericardium is hyperechoic?
Yes.
Or
Yes, you can. And that is what I'm saying, that many a times when you learn to experience echocardiographic images time in and time again, I think the relevance is that at least 200 monitored and 200 non-monitored echoes should be done before you are able to actually convincingly say what is normal, what is abnormal. So, yes, there are a lot of areas which you can say fibrotic. Pericardium is fibrotic, but I would say that let's not focus on the pericardium. Let's look at the normal myocardium. You should characterize the normal myocardium, and any segment of the muscle which is myocardium which is showing a more fibrotic or more white kind of appearance is definitely suggestive of scar. It may not be so fibrotic as pericardium. Yes, to the extreme you can go there, but I would say that you should learn to characterize the quality of myocardial imaging, ultrasounds. And when you look at the myocardium, anything which is denser with the rest of the myocardium is obviously scar.
Thank you, sir. One more question for same purpose. Sir, whenever sclerotic degenerative disease of aortic wall and mitral wall, sometimes it's confusing. So, any reference point for that particular thing, sir?
So you are talking about when the mitral and aortic valve was sclerosed. Again,
Yes,
this
sir.
means thickened as well as restricted movements as well as more fibrotic, right? Right. So
Yes, sir.
I would say simplistic terms, the valves, aortic valve is minimally seen in a four-chamber, two-chamber, and parasternal long axis views. Again, you'll have to see the normal aortic valves to convince yourself what is so-called minimalistic scene. That means they should be thin, they should be pliable, and they should be relatively seen. Whenever it is more fibrotic, one component, one portion is fibrotic, it's easy to understand. Say, for example, from the three leaflets, one cusp is more thickened as compared to the rest of the things. It's easy. But as I said, you have to learn to look at what is normal, what is abnormal. In theory, it is very difficult for me to tell you how Dr. Rakesh Gupta looks like. But once you see and you learn to see Dr. Rakesh Gupta, then you would definitely differentiate Dr. Rakesh Gupta from Sanjay Mittal.
Yes, sir.
Dr. Shikha Jain.
Hello.
Yes.
Good evening, sir.
Shi-
Sir, how to identify this four chamber views foreshortened? मतलब what the landmarks, sir?
Okay. I simply say when you saw those images, the right atrium, if you looked at the right atrium, it was not like this. It was like this. Okay. That was the catch. Second thing is, I would always say to avoid this mistake, when we start the parasternal long axis view from here, look at my chest. Okay, I'll do this. This is where you start the long axis view. And then we have a bad habit of moving to the apex. And as soon as we see the four chamber, we are very happy. The best way is keep on moving out and down, keep on moving out and down till the time you lose the heart. And thereafter, you start coming back in when you start seeing the four chamber view. This is the best way to avoid any kind of foreshortening. Okay? Otherwise, we'll keep on committing the same mistakes again and again.
Thank you, sir.
Anybody else? All right. Thank you, Dr. Sanjay, for excellent, as usual, the deliberation is clear-cut thoughts, clear-cut ideas, how to identify proximal mid-distal LAD. And that's what exactly happens when we talk, a legend talks about echocardiography. Thank you very much. And I'll just take an attendance of all these people before we disperse.
Okay.
Okay. Thank you.
Okay, Professor Saab, I'm leaving.
No, I'm not professor, but I tell you very important thing.
Hmm.
Ever since I have become stricter in their attendance and their examination, every module we are conducting an examination.
Okay.
So once we'll complete CAD cardiomyopathy, we'll go to Google exams. It's a 2 hours exams. We'll send a link just 1 minute before, and they have to submit within next 120 minutes. So
And
the
there's
link,
no way there's no way they can cheat.
even if they cheat, they can't complete the questions. And in turn, out of that is so many people are working so hard to get through those exams, because those who will complete the attendance and clear the exam will come for hands-ons.
Excellent.
So that's how the interest is getting generated every day, every year.
I wish everybody best of luck and happy learning and happy utilization of all that you learn in clinical practice.
And in fact, if you learn and you'll give back to society, that's what I always say.
Exactly. That's how the country would progress.
The God has given so much to us by making us a doctor. It's our turn to give back to the society.
Excellent. When are you standing for elections?
Where?
I mean, I was impressed by your speech, no? So when are you
No, I'm
standing
not
for elections?
standing. Look, the day I stopped politics, I'm doing much better than before.
Okay. Thanks for the opportunity.
Thank
See
you
you
very
again.
much. God bless
Okay.
you. Take care. All the best. And if you want, you can disconnect. Otherwise, you can listen to that question now. This attendance sheet also.
No, take care. Bye bye.
All right. Thank you.